I want to welcome you. My name is Kathie Kane-Willis. I'm the director and co-founder of the Illinois Consortium on Drug Policy. We were founded in 2005 to bring discussion to alternative voices to our Illinois drug policy issues. So this is our 9th year of existence. Next year will be our 10th year, and it will also be the 5th annual forum on drug policy. And just reflecting back on how much change has occurred in these 4 years, it's just amazing. I don't know, for folks who are interested in overdose reversal, naloxone, FDA just approved a device that makes it possible to have the nasal naloxone and naloxone all together in one piece. That happened yesterday. Brought some very interesting results on decriminalization of marijuana. I don't want to give away the big headline, but so you'll have to stick around for that. But I mean, you know, compared to 4 years ago, I think the landscape has entirely changed. And so I want to thank you all for coming. I want to thank Roosevelt University, the Policy Studies Organization, and Students for Sensible Drug Policy, Student Advocacy in Action. It's really awesome to have students a part of this movement and, you know, driving this forward. So we're going to begin with our first panel, Inside and Outside the Walls, perspectives on individuals who use drugs, treatment in the correctional system right now. And I'm not going to read anybody's bios. You know what? They're fabulous. All of our panelists are fabulous, but we have too much to do and too little time. And you know what? I suspect you can read them faster on your own than I can read them out loud. So I will introduce the folks around the table, and we're going to have a discussion. So I know people are going to be passing out, you know, index cards, and feel free to write down your thoughts, your questions, your ideas. So we're thinking about, you know, an hour for the talk and then 15 minutes for questions, which probably won't be enough, but you can, you know, hit up the panelists during the coffee break and get them to answer your really tough questions. So let's begin. Thank you so much for coming. Thank you for coming. So I'm taking this, excuse me. And so on our panel we have Katharine Neill from Old Dominion University, and she's going to start. We also have Beth Jantz from the Federal Defenders Program, Marcia Bazan. She works at the Metropolitan Correctional Center. Lucian, or I can never say your last name. Say it. Israelov. Okay, so now I can say it. Peter Moishin and Ryan Dalton. And you can read all about them on the agenda. That's what I'm doing, but you can already know them. And also in their bios. But first, I sort of, the way we do this is we often take an academic paper and we build a panel around it. So the academic paper that we took through PSO was Katharine Neill's. She has written about U.S. drug control strategy, and she's going to talk a little bit about what she found in her academic paper. Now, the reason why there is no PowerPoint is because we do not like to have academic presentations, but we want to have a discussion around this. So why don't you set the stage for us, Katharine, and tell us what your findings are.
Hello, everyone. My research primarily has focused on the social construction of drug offenders and how the socially constructed images that we have of them in society have shaped the laws that we have passed directed towards that population. And I've looked at laws at the state level, focusing on most of the drug war era, so from 1972 to 2002. And what I found is that, for the most part, the way that when drug offenders are socially constructed in a negative way, so when they're viewed as deviant, as a threatening population, we're more likely to pass laws that are more punitive towards them. And my findings have supported this idea in the sense that states that are more culturally conservative and that are more punitive towards welfare policies, so they have more punitive ideas about poverty, and where they also have larger black populations, and especially where large black populations overlap with poor populations, we see that states tend to pass laws that have longer sentences for heroin and cocaine and marijuana sentences. So that's, I'm sort of still in the process of going through all the findings that I have and teasing out some more nuanced things, but that's the basic finding that I have. And if you look at U.S. drug policy historically, it has been a tool for social control. And you can see this going back to the late 1800s when they started to pass opium laws in the western states that were primarily directed towards punishing Chinese immigrants that used opium in those states. Later in the South, there's also concern about cocaine use among blacks. And then at the federal level, in 1914, the Harrison Act was passed. And this was the first major federal legislation that regulated drugs. And the primary purpose of the law was to regulate opium sales, and it required physicians that sold opiate derivatives or cocaine to pay a tax on that. It was very forcefully enforced by the federal government, and so one of the effects of this was to construct drug addiction as a criminal issue rather than a medical one.
Wait, may I just
Yes,
ask you?
yeah.
So, Katharine, what you're saying is before 1914, drugs were not illegal. Is that what you're saying?
At the federal level. The federal government didn't regulate them before that, but states actually began to regulate them earlier than that. And again, they started to pass their own opium laws, the western states did, mainly out of concern for Chinese immigrants, and then in the South they also started to pass drug laws, but it wasn't federally regulated until 1914.
And I mean, when we think about that, I think most people are surprised by that kind of information that drugs were one that's actually legal.
Yes. Yes. And actually, the purpose of the Harrison Act was, on paper, was a revenue act, a tax. And you know, I didn't go into too much into detail of this and get us off topic, but the way it was enforced, it was an opportunity for some of the federal agencies to really expand their power and their resources by framing the issue as a criminal problem, and that in turn sort of strengthened the power of these law enforcement agencies and their resources, and that was one of their incentives for really focusing on the criminal element of drug use and drug addiction.
So, I know the primary thesis of your paper is sort of that that drug control strategy has not resulted in a health policy strategy. Can you tell me a little bit more about that?
Yes, I argue basically that there's two frames of the way that we perceive drug offenders. So you can either see drug offenders as a problem of public safety or as a problem of public health. And the dominant frame that we've had really since this federal legislation was passed in the early 20th century was as a law enforcement issue. And the effect of that is that we've really neglected the public health part. And there was a time actually after the Vietnam War when you had a lot of veterans coming back from the war, they were addicted to heroin. And you also had the youth culture at the time that was very into experimenting with marijuana and LSD. And at this time, there's probably a little more tolerance for drugs because of the populations that were using them. But then if you get into the 80s and you see when the drug war started, there was a really crackdown on drug users. And the rhetoric at the time didn't allow politically for any kind of focus on treatment. You had to appear tough on crime and tough on drugs. And what that translated into was laws such as mandatory minimum sentences that really punished users and defunded treatment programs. And because of the dominance of this criminal approach towards drug offenders, there wasn't really a political incentive to pursue treatment options.
And so, I mean, I want to move on to Beth Jantz, who now has to deal with sort of the repercussions of the system that's been created, and I want you to chime in, because I don't want this to be, okay, 3 minutes we talk, and then, I really want this to be, and I know Pete wants to say something about Vietnam, because I know he had something to say about that. But Beth, can you talk about your experiences in the Federal Defenders Program and mandatory minimums and what you see with
people who use drugs?
Sure. So my name is Beth Jantz. I'm a public defender exclusively in the federal courts. And in my role as a public defender for folks, I see drug use in two different formats, basically. One, lots of my clients who commit crimes that have nothing to do with drug trafficking are themselves struggling with drug abuse, mental health issues. A huge one is we do a ton of bank robberies, believe it or not. There's like a bank robbery a day in Chicago. The good news is most of these are done without guns, and almost 100% of my clients have substance abuse issues or mental health issues. And the upshot of robbing a bank without a gun usually is you get 5 or 6 years in jail, it's not automatic, but that's generally what you get. And so when we talk about this, this dichotomy between criminalization of drug use versus treatment, it has been traditionally we put people in prison for 5 or 6 years rather than getting at the root source of why they went into the bank in the first place, which is they're struggling with these other issues that treatment would really help with. So that's the first way I see that in my practice. The other half of it is the federal criminal drug laws that we've been talking about a little bit that aim at drug trafficking, they will say, although again, most of my clients, and the public defense system and the federal court system represents about 80% of people. It's really expensive to get a private lawyer in the federal system, so it's not as if we're only seeing a segment of the population. Most of my clients who charge with drug trafficking are corner guys. I mean, these are not the higher ups. So they charge higher ups once in a while, but again, these are folks who are making very few dollars and often struggling with drug abuse themselves. And in terms of what's been going on, in the last 20 years, the number of people in federal prisons because of drug crimes has doubled in 20 years. And the total number of people in the Bureau of Prisons right now is about 200,000. A third of those are there for drug crimes. And you may hear what I would refer to as rhetoric of the federal government saying, well, we're really going after the hard stuff, the real serious problems here. The most prevalent kind of prosecution that results in people being in prison for drug crimes is marijuana, which was surprising to me. And powder cocaine is next, meth, crack, heroin in that order. But marijuana is the largest number of prosecutions that results in folks being in jail. And so I think the good news is that we've seen some good progress really over the past couple of years. We talked about this history of the drug laws, and one of the things that happened in the 1980s is there was this scare about crack cocaine. And there was this great basketball player by the name of Len Bias. He came out of college like 86 or something like that, and he ODs. And it was publicly reported that he OD'd on crack cocaine. He didn't. It was powder. But it was reported that way, and the Congress passed very draconian crack cocaine laws that punished crack cocaine versus powder cocaine 100 times more stringently. You could have 100 times more powder cocaine and get the same punishment. And the big upshot of that was a lot more people go to jail for a lot longer. The people going to jail for crack cocaine were mostly folks of color. Finally, Congress has started to rectify this, and the amazing part is not just the Democrats, it's Republican support too. And that gives me some real hope that we're moving away from this just throw everyone in jail and let's talk about real treatment and public health as being a more economical result.
Well, I want to move to sort of what treatment looks like, and Marcia, I know you've worked in the jail as well as in the federal correction system, and so I kind of wanted you to a little bit talk about that, and then Pete, I know, has some pretty significant experiences. So I mean, however you want to let this go, but I want us to think, we think moving to treatment within a system, that's a positive step, but what does that really look like? What does that treatment look like, Marcia? Tell us what that looks like, and then Pete, jump in when you...
Mm-hmm. So as part of my clinical training, I've trained at Cook County Jail with women in Division 17, and I'm currently at MCC Chicago, the Metropolitan Correctional Center, working with incarcerated men. Treatment is completely different for many reasons. It's considerably different to work with female inmates and male inmates, but there are some similarities in terms of the treatment provided while incarcerated. There is, I feel, a recognition that substance use is needed. The correctional field has become the world's largest mental health provider. And so in both Cook County and within the Federal Bureau system, there is stressed the need for evidence-based practices. So specifically the use of cognitive behavioral therapy and motivational interviewing. So there is the recognition that there are a lot of people being arrested and incarcerated for drug offenses, and so we need to provide some sort of treatment while they're here. They're completely different though. My experience in Cook County, working with the women, in Division 17, they had more of an empowerment approach. They recognized inmates and referred to them as participants rather than inmates. The correctional officers appeared more informed of mental health concerns. And we focused on trauma and the correlation between trauma and addiction with women. Some of the weaknesses in Cook County, though, are that I know you hear the word evidence-based practice a lot, but it doesn't necessarily mean the providers are knowledgeable about drugs and their effects. I've witnessed a large spread in terms of drug knowledge within Cook County. Within the Federal Bureau system, I feel like the structure is more consistent. In the Bureau, inmates are offered drug education, non-residential drug treatment, which is a group that I'm running now, and residential drug treatment. The groups within the Federal Bureau system are, I feel, more organized than the county provides. In the Federal Bureau, we conduct psychosocial drug interviews. There's individualized treatment plans. Participation in groups are evaluated and monitored and measured. In Cook County, it seems to me like it's more like, does it feel like it's working? There isn't really a consistent measure of outcomes. In Cook County also, the women are mandated to treatment, and they're sent there for 120 days. That's a standard amount of time. So it's 4 months of your life spent incarcerated. Not to diminish the importance of men in the family dynamic, but it's difficult to provide substance abuse treatment with women who are usually the primary caregivers. They're removed from their children, and my experience running substance abuse groups with women is that the majority of the time you're dealing with them worrying about the welfare of their children, and they're not very invested in treatment. They're very distracted. With men in the Federal Bureau system, it's voluntary. So if you're interested in treatment, you're going to get into a group. Not right away, things take time, but you will be enlisted in a drug treatment program. And I feel like participation there is, they're more invested. By that stage, they have recognized that some things need to change. And so it's not ideal in either system, but I've had a lot of clients come to me and say, if I hadn't been arrested, if I hadn't been incarcerated, I would never have gotten treatment. And so that kind of leaves me wondering, what is it about maybe the community treatment offered that keeps them from entering treatment before being arrested, before having some sort of intervention by the correctional system?
Do you think it's possibly the lack of treatment in Illinois? I mean, in Chicago?
Yes.
You know?
Yes.
I mean, just to say, sometimes it's kind of hard to get into treatment, particularly with the funding cuts. But I know Pete.
Yes,
Pete has got.
I've worked in methadone treatment and worked with people with mental health problems and substance misuse problems forever, it seems. The biggest problem I see for my clients and my patients is the stigma that that's attached to their drug use and to their treatment. In many cases, people feel very ashamed about their use, and yet when they get onto a methadone program, the shame follows them into their treatment. And I'm just wondering where they get to feel good about themselves in this world, if those are their options many times. The stigma also butts up against the judicial system. We've had patients who did well in treatment, but because they were still involved in the judicial system, they were given choices by their judges to either get off of that methadone or go to jail. Not a choice many people want to be able to, not a choice many people want to make. Everyone I knew got off of our program. No one wanted to go to jail. Everyone got off the program. Resulted in some people doing all right, resulted in a lot of relapses, and resulted in overdose and deaths for some. That stigma follows them, unfortunately, in the healthcare system also. I've seen patients be discriminated against because they're on methadone. And it's something that generally you're told to tell your healthcare provider about all of your medications, about anything that would be pertinent to him knowing more about you. My patients, I've counseled to keep their mouth shut unless they're talking to their anesthesiologist. I've seen people told that they don't deserve hepatitis C treatment until they get off of that methadone. Certainly, that's not everyone. Many people are supported in their treatment. Many people are supported at different hospitals. They see treatment as a benefit. But it's a long, slow road. It's been, I mean, people have been feeling this stigma for 20 years, and I believe they are still feeling this stigma today. It maybe has lessened in some areas. But I'm prejudiced. I live in a big urban area.
Right. Would you say, so you began your work, I mean, when Katharine was talking about
yes,
Vietnam.
my first work was in the 70s when I was in the Army as a medic. I was a drug counselor working with returning vets from Vietnam.
And would you say the stigmatization of drug users has become more? I mean, was methadone more acceptable, say, in, you know, back then? I mean, what was the viewpoint? How were people who used drugs or had substance use disorders treated then as compared to now? I mean, do you think it's worse? Are we in a better place? Are we in a worse place?
I think we're, both ways. It goes both ways. It's different layers. In some areas, we're doing much better with treatment because it's much more patient-centered. Mm-hmm. They're taking what the patient needs into account. Mm-hmm. Where rather than just having the blue plate special of treatment options, it's a smorgasbord now. Mm-hmm. For many people that they see different options for them to choose from to get better. In some cases, though, people are still dosed extremely low at programs. People are still punished for positive urine samples and have their doses reduced in many places where really the answer would be to raise someone's dose if they're not feeling right from their medication.
And I mean, Lucian, you have experience actually receiving treatment both inside and outside of the criminal justice system. And I want you to respond in a way to both to everybody, but talking about your experiences, you know, with evidence-based treatment, I mean, what was the service, you know, what kind of treatment did you get inside the walls? I mean, what did that look like?
Okay. Well, based on my experience, the last time I was in treatment was in 2010 inside Cook County Jail. The first time was in 98. You know, from what I've researched now and from what I've been hearing on the panel is that there's a lot more effort being made as to like the heterogeneity of the disorder. You know, but I mean, I believe that we are so far from reaching a point to where we can help the people who suffer. You know, to use myself as an example, ever since I was a kid, I had a chronic fluency disorder, and you may hear it now that I stutter sometimes. But being in and out of treatment for so many times, like at least 6 times over the course of, I don't know, like 12 or 13 years, you know, it never even like crossed anyone's mind that maybe that caused me to have a little bit of a social anxiety. And when I had my first drink at the age of 15, that anxiety actually would dissipate. So then I was able to correlate to self-medicate as a way to cope with anxiety, and then I learned how to cope with other things, such as stress, whether stress was good or bad. Because even when I got my life together, and I had a child, and I had a successful company, you know, I didn't know how to deal with all the good. You know, I mean, our bodies don't differentiate between what is good stress or what is bad stress. You know, so I still reacted the same way, and I went back to coping the way I knew how to cope, and that was to self-medicate. You know, ever since I walked, you know, from every treatment I've been in, you know, I was told I have a disease, and I was told that my medicine was to go to meetings and to find God. You know, I mean, knowing me, you know, I question everything, you know, and it's like, okay, I mean, a disease I know is like cancer or diabetes, you know, and people take medicine, they go to therapy, you know, but I have to go to meetings and I have to find God. You know, and I was also told that I can't do absolutely anything. You know, it's like, and if I do, I will suffer, you know, but I had to see it, you know, and I suffered, you know, but I mean, I don't want to say that what they told me was right, because, you know, only from being in school here in Roosevelt and learning just the tip of the iceberg about psychology, I found like a huge correlation, you know, between stress, cognition, behavior, with neuroscience, with society, and perception with substance use disorders, you know, and all that combined is not addressed in a treatment, in a rehab. You know, I mean, it's like almost like they're using a homogeneous approach to a heterogeneous disorder. You see what I mean with the speech disorder? Yeah. So.
Well, we applaud you sitting on the panel and
Yeah.
you know, working through this and telling us your experience, because I think it's really important for people to hear, oh, you mean what treatment looks like inside, outside, often is go to meetings and believe in God.
Right.
I mean, that's what treatment looks like, and as then you study it, you know,
Right.
and I think there are a couple of treatment providers who would be like, wait, that's not really what treatment is.
And that's not evidence-based treatment.
It's not.
Evidence-based treatment is, you're supposed to individualize treatment to a client using research-supported interventions, not one-size-fits-all. Unfortunately, though, given the number of people in my experience that are incarcerated, I've had to run groups that were 15, 20, 30 people. That's not individualized treatment. And I leave those groups and people yell for me and ask me to see them one-on-one, and that's the treatment that they need. Unfortunately, we just don't have the resources to support that.
And Ryan, I mean, I just want to, I know that you didn't receive treatment inside the walls, but, you know, tell me about your experiences in treatment, and, you know, are there any intersections with what Lucian said, or was your experience totally different? What did that look like for you?
I think in some cases it was the same, and in other cases it was different. I received it at a private inpatient rehabilitation center, and my treatment was voluntary, so it was my choice to go. I feel fortunate enough that the program that I took part in was largely evidence-based. I was what's called dually diagnosed, so not only had I been suffering from an illness, like an addictive illness, but I also had anxiety and depression. And I think a lot of times in the realm of drug rehabilitation, that is overlooked. I think Lucian put it very well when he said that it's a homogeneous, solution for a heterogeneous problem, and that plays into the fact that the dual diagnosis is kind of just grouped in there. So they addressed that separately with cognitive behavioral therapy. On the other hand, as Lucian said, I think a large part of it was the Minnesota model, God, a spiritual awakening, 12 steps. And while, for me, for my individual recovery, that provided a good foundation, at a point, it becomes, it's not enough. There needs to be something more, and I think more emphasis could be put on that aspect.
Katharine?
One thing I wanted to address is the idea, we heard a couple of comments about the lack of resources. And my view is that it's not that we lack resources, we just choose to spend them on things other than treatment. When you have an entire federal agency, the DEA, that's completely about prosecuting and investigating drug crimes, the ATF, another federal agency to a lesser extent, frankly part of my salary. And the amount we pay to have people in the Bureau of Prisons is between $20,000 and $30,000 a year, which is a great college education. I don't know what Roosevelt costs, but it's probably somewhere around there. And most of those folks are nonviolent offenders. So this idea that we have a lack of resources, no, we're just spending them in different ways. And if we could have more treatment providers at the MCC, there's folks there clamoring for one-on-one. Isn't that the best way to cut down on recidivism rather than just locking people up for a longer time? So it's troubling to hear, and a lot of my clients are over at the MCC, that people want treatment and there's just not enough of the good treatment providers because we just don't allot enough money. So I think that's an important thing that hopefully, I think the tide is turning a little bit. Let's hope it turns more, I think.
I have a comment, actually.
Okay, and I think Katharine does
Okay.
too. So maybe can we share? Can we pass the microphone down? Okay, that's cool. No, we're good.
So I've had actually a number of clients come up to me and say that they opted to be reincarcerated rather than to continue treatment in the community. So they left treatment, they said, I couldn't deal with this, lock me up, put me away, I'll serve the rest of my time in MCC. So, I mean, that says something, I feel like. What is it about the treatment that is available in the community that they're staying away from? They'd rather be incarcerated than, to touch on your point, than to be labeled an addict, than to have to sit through AA meetings when they don't really apply to them. So I just wonder, what do you do then with clients that you give them the opportunity to access treatment in the community, but then it doesn't fit them, and they'd rather join a drug treatment group while they're in prison?
Wait. Katharine next, then we'll go to Lucian, and then we can, I think, Pete, do you have something to say? Yeah, okay.
I actually, to both of your points, you were talking about how they would rather do the treatment in prison, and that kind of, to me, reminds me of one of the issues with the drug courts. And drug courts now are just one of these popular alternatives for, to incarceration where, for in exchange for a reduced sentence or for no sentence, you undergo this voluntary treatment. One of the unintended consequences, though, of this is that the drug courts often have very stringent requirements. They require you to have time, resources, transportation to all of these, different treatment programs and meetings. And for clients that, either you don't have a lot of money, you don't have transportation, you don't have a babysitter for your kids, it makes it very hard to comply with some of these requirements of the treatment in the community that's mandated by the court. And that actually, what happens is that some of these people end up getting incarcerated for longer than they would have for violation of these agreements with the drug courts. and then to what you were saying about the funding and the money and how we're choosing to spend the money, I completely agree with you, and I actually was looking at this earlier today. In 2011, the federal government spent $7.6 billion on law enforcement. This is compared to $3.9 billion for treatment and just $1.7 for prevention. So it really shows you in terms of the spending where the priorities are and where the money is continuing to go. And this is as recent as 2011. I think that the new budget still asked for about $25 billion for the war on drugs versus only 15 to fight or to treat drug treatment. So even as we see these changes in policies, either a lot of states are kind of realizing that treatment might be a more cost-effective way to deal with drug abuse than incarceration, we're still seeing the money very much tilted towards the law enforcement side of things.
Yeah, speaking of funding, okay, the company which I had was a chain of recovery homes here in Chicago, which I had to resign from because of my substance use. But from what I've seen, places like Safe Haven and Haymarket, they get pretty much over 90% of the state funding for treatment. But their treatment is not research-based. It's all experiential, based on the staff and the experiences which they went through. And they use that, and also they watch the success of a small minority of people who are actually able to succeed. And if it doesn't work for you, they say it's because you don't have the willingness. Well, maybe there's something a little more to it, Maybe, they need to spread the funding more than to just two places, here in Chicago.
Yeah, if we're going to talk about substance misuse as a disease, then we need to treat it like a disease, and we don't. I mean, it's very rare I've ever heard anyone with diabetes told that they need to get to a meeting, they need to get their relationship with God in order. If you give me a positive sugar urine, we're going to have to reduce that insulin dose of yours because you're not being compliant with your treatment. You laugh, and I would agree. It's funny if you think that someone on diabetes would have to go through that. But believe me, someone on methadone does go through that constantly, every day. And they again, if it was treated more like the disease it is, and not, it's our labeling also. I mean, we label people as abusers. I've never met any people that abuse a substance. I've met people that misuse it. Abuser is a very derogatory term. And yet, that's what our government agency is called, I believe, National Institute on Drug Abuse. Mm-hmm. So from the top down, we get this message. It's going to be hard to convince everyone that evidence-based treatment is where it's at. We're having a hard time doing it.
Katharine, did you have something to add to that?
Oh, well, just to that point, I would, say that one of the things now, again, we're seeing a lot, especially at the state level, you're seeing a lot more focus on treatment and on reducing mandatory minimum sentences, finding alternatives to incarceration. A lot of this has been driven by budget concerns. So states don't have any money. They say, hey, it costs way too much to lock up all these people. Let's do something else. But it hasn't really touched on the idea of substance use as a disease. It's really more focused on the economic side of it. And while I think that pragmatic part of it is a good way to begin the debate and also to get people on both sides of the aisle of the political aisle to support drug reform, I'm kind of cautiously optimistic about it because I think that to the extent that your main concern is saving money, this can kind of result in a sort of leaner and meaner justice system. So then you see cutbacks in other programs within prisons, so maybe less treatment because treatment costs money also. And so I think that gets back again to how we frame the debate and how we frame the population that is using drugs. So if, again, just like Peter was saying, to really emphasize the fact that drug use is a disease is very important to, I think, long-term change and to investing in the kind of treatment that will prevent recidivism rates and will bring down other kinds of crime, and also to, help people that are having problems with drugs, stay off those drugs for a longer amount of time.
Well, is that our goal in treatment? I mean, I sometimes wonder, when we talk about functionality of an individual, let's say with diabetes or a mental health disorder, we're looking at their overall functioning. For the people experiencing treatment and also delivering treatment, I mean, what is our eventual goal? What is our goal? Is it to count those non-positive urines as a marker of success, or how do we measure effectiveness in terms of treatment? And is there a different way than just simply looking at someone's urine? How Pete, do you do this? How, Marcia, do you think about this?
I believe that as far as urine samples go, patients should be required to give urine samples when they feel they want to demonstrate their progress in treatment. And that's the only time I'm ever concerned about getting one from them. If I was to get one from them and catch them doing drugs, wow, what a surprise for me that I have a client who has a substance use disorder that's actually exhibiting a symptom of their illness. Not something they should be punished for. I'm pretty sure about that. But that can be heresy in the treatment community when you talk about that, because many people feel that you need that concrete urine sample. And that stopping use is the final end of it, which I'm not sure of. I expect my clients to examine their relationship with their substances. And I see addiction equaling pain and recovery equaling forgiveness. And if I can help them through that, then I'm doing my job.
Marcia? Put down the spot here.
Yeah. So in Cook County Jail, in the Federal Bureau of System, obviously the goal is abstinence. However, I frame it from the client's perspective. I use their ultimate consequences, their ultimate objectives, right? So if your objective is to never come back here again, to stay out, what do you need to do? And is your behavior aligned with the way you want to feel, what your goals are in life? And so within the system, abstinence is the goal, but I do frame things from an individual perspective. In a group setting, though, it's not that individual, and people walk away with what they walk away with. If they don't believe that this is treatment, then they don't believe that this is treatment, and it's obviously not going to work. And treatment is very much, it's so different based on who is providing it and the perspective of the provider. And so I'm a little bit more open-minded. I've decided to infiltrate the system and kind of introduce some harm reduction tactics, but other people come from a very different perspective, and that's what they're going to push in group treatments.
And Beth, just to ask you, how do you think judges would respond to the idea of functionality versus abstinence?
Not well, generally. So a large part of our practice is representing clients who have been in the state system. They call it paroled from jail, and they're on essentially parole. We call it supervised release. Nevertheless, I constantly get clients who are brought into court because they've tested positive for the use of marijuana, and they're warned, if you do it a couple more times, we're going to throw you back in prison. And it's just, and the statutes are written that way, so it's not as if, I think the judges, some of them do want to have them more open, many of them do, but it's this black and white, what is your urine showing? That is the test in federal court generally, and lots of our judges are increasingly becoming open-minded, and they won't send people back for that alone, but it's a constant reason you're in court, and it's not ever about, let's look at the positive things. This person has a job and he's made a good relationship with his family and sees his children and all of it. And you say all those things and they're like, but he tested positive. So not well, but we're working on it.
Right. And Lucian and Ryan, I mean, you guys, I know your sort of your personal stories. I mean, how do you conceptualize recovery, not just for you, but for other people? I mean, how does this sort of tension play out for you? Because I know you guys are both abstinent, and you know, like, at what point did substance use disorder sort of, do you know what I mean? Wait, can we talk about that kind of tension between, you know, sort of using and then the substance use disorder and recovery, and how you would view somebody who is functioning but maybe still use substances occasionally?
I mean, I think, as is kind of the theme up here, it's a very, both sides of it is a very individual thing. I know in my experience, and kind of expounding on what you had said in terms of, you know, sort of destigmatizing it, I think that the way that's done is very, it discourages a person from wanting to get help. I mean, in my experience, the first time that I went through treatment, it wasn't because I wanted help, you know, with my addictive illness. It was because my parents had kicked me out on the street, and I was homeless, and I was kind of just bored with that, and I wanted to sleep in my own bed again, and I wanted, you know, 3 hot meals. So I said, oh, you know, I want help, and, you know, so they provided me with the treatment and also let me move back in, and I wasn't sober for, you know, 3 days in a row. I was drinking on the weekends, and it wasn't until 5 years later where things had just hit, you know, we use the term rock bottom a lot, that I wanted to go for myself, and that was the last time I entered treatment, and 4 years later, you know, I remain abstinent. However, I think that the way that treatment is approached and the way that the laws are set up in terms of drug policy is very discouraging to people who might want to get help, face that proactively. Why would you want to put yourself out there for, you know, to be subjected to such criticism? You know, I got to a point where I really didn't, you know, excuse my language, give a shit what anybody thought, and that's why I did it, but there's a lot of people who do.
Is it, I mean, in some ways I think what you're getting at is the rejection of the label being such a heavy weight to carry, and that might drive people away from that. And Marcia, you kind of alluded to that with the folks who didn't want to receive treatment in the community, and I know Pete has talked about stigmatization. And I mean, as we talk about people with substance use disorders or people who use drugs, and this is really the new language that we like to use, and there are studies that show when you use the word substance abuser and you give somebody a clinician the same case history, they're going to treat the person differently than if you say person with a substance use disorder. But I wonder how much, you know, we talk about, you know, one of the symptoms of like substance use disorder is denial, but how much of it is denial of the label? Like, I don't want to be, you know, all the baggage that comes with that. And how do we flip this paradigm? I want to move to let's make a change and let's get this, you know, let's make the world a better place. How do you see your role in changing things? And I'm going to ask this of everybody.
Okay.
Oh, no, that's fine. Well, I would say that one of the ways to change the framing, and I think that some of this has started, but it's really to bring the conversation, you know, out into the public more than it is right now. So in the 1980s, a lot of the drug war was fueled by the media and the media's depiction of crack cocaine and, you know, and drug crime is related to street crime and violence and all of these things. And that was a big part of it. So I think that if we can kind of change the coverage of the issue, emphasize not necessarily the violence that occurs with drugs and drug-related behavior, but the pain and the struggle of people that deal with it, the overdoses. I mean, now we've seen more about heroin and pharmaceutical drugs and the problems that people are having with those and overdoses. You know, Philip Seymour Hoffman obviously was a very public example of somebody who just overdosed on heroin. And I think that issues like that, just in the same way that the Len Bias overdose in the 80s kind of fueled this need for more punitive legislation against crack, that now things like that we can try to focus on it more as a disease and as a problem that really affects individuals. And I do think that we have seen people doing this to some extent. The governor in Vermont used his State of the Union or State of the State address to really focus on the need for more treatment for drug offender or for drug users. And there's also evidence that the U.S. population is really seeing treatment as a more viable option. There was a recent Pew poll that said that 2/3 of Americans now think the government should focus more on treatment than on incarceration for drug offenders. So I think that it's really focused on changing this conversation and changing the framing of it, and I think that does involve, to a large extent, the media and getting that message out there and the way that the issues are covered.
And Beth, I mean, working inside the federal system where you've got the sentencing guidelines and, you know, not a lot of room to maneuver, how do you see that?
So I think two things. One, I think there is a lot of positive momentum in the law in terms of making our drug laws less draconian and giving judges more discretion by taking away mandatory minimums. There's still inequity. Crack cocaine is still penalized 18 times more than powder cocaine is. It's 18-1 in the federal system. It's no longer 100-1, so we've made some progress. There's a ways to go, but I think I referenced earlier something called the Smarter Sentencing Act is going through the Congress right now. It's got bipartisan support. It would bring down a lot of the draconian nature of these drug laws. It's not perfect, but we're getting good momentum. I think it's driven by economics, but at the end of the day, if it helps my clients, I'm all for it regardless of the reason. I do think the second point I'd like to make is I wish, though, that we'd put a lot more dollars away from enforcement and into treatment, and I don't profess to know what kind of treatment is best. Sounds like there's a lot of great ideas up here, but war on drugs prosecutions hasn't worked, so let's try something better and different.
I would stress education. If there were a way to talk to judges and tell them, educate them about evidence-based practice, that methadone maintenance is an evidence-based treatment, and that it's okay to have clients on that type of medication, that would be great. So education across the board with lawyers, judges, clinicians especially. Sometimes what's preached is based on personal experience or bias rather than on research. And so just knowing what studies have been done, what works best for my client, and integrating that into treatment would be phenomenal. Whether that's inside the walls, in a jail, in a prison, in the community, ideally, we need to be providing consistent treatment. And it shouldn't matter whether someone has a lot of money and can afford months and months in rehab, or somebody was mandated to attend treatment on the south side of Chicago. The kind of care that they should receive should be equal, should be comparable.
I would agree education is going to allow the most bang for your buck many times. People aren't going to change their attitudes unless they learn new information. And people will never change their actions unless they change their attitudes about things. So it starts with education. And there definitely needs to be more funding for treatment. It just is not available to people that want it. Whether it's for cocaine treatment, alcohol treatment, heroin treatment, there's just not enough dollars available. And it does go for incarceration. Lots of money for that. That's all I got.
And for Students for Sensible Drug Policy members who are both in recovery, I mean, I think this is kind of an interesting position, right? Like you're advocating for the change of laws, and you're a person in recovery. How does that, so what does that change look like to you?
To me, it looks like hope, because it looks like hope for people who are younger. They were really quick to bring DARE into schools and to misinform all the kids about, how illegal or bad it is to do crack or cocaine or any of that. But like a lot of it was overblown. I think just like, as you said, education and educate kids at a younger age on what these drugs actually do and what may or may not happen, might work out a little bit better. And I'd also have to agree with funding issues. Instead of, even with the small amount of funding which we do have, I'd say to spread it more to individualized therapists, because those are the ones who can take the actual time to get to know somebody, one person at a time, and see what if and what may be an underlying issue, because usually there is one,
Well, I think for me, first and foremost, like Marcia would be a great example of, I think, what needs to be happening on the front lines in terms of individualizing and sort of tailoring a person's treatment to their specific needs when it's, when that's possible. And obviously, drug policy reform, like you said, Kathie, I mean, I sit up here as a person in recovery who advocates for, the reform of drug policies, and they may not seem to go together, but, I wake up in the morning and I make my decision not to use. But, that's because I know that I can't use in moderation. But that doesn't mean, that's just not a blanket thing. It's very different for everybody, and I think that being able to kind of look at it under a microscope like that, would make people realize how case by case, unique that it really can be.
Well, I mean, SSDP folks are people who feel that they can answer this question without, jeopardizing their livelihoods. Do you believe in decriminalization?
Yes. I think there's a number of implications, in regards to that.
And, a lot of times people have a misunderstanding of what decriminalization is opposed to, say, legalization. And so just to say decriminalization, when I talk about, when I say that, when I'm saying that, and I'm going to speak for myself here, means not imposing criminal penalties for people who possess drugs. Would you be supportive of something like that in the United States?
I know I would.
Absolutely. I think that people, speaking of me, it's like with I'm also abstinent. But my abstinence came with, with almost like you can relate it to learned helplessness. I've had to go through pain over and over and over again until finally I did what they said and surrendered. But like, I don't think that people have to go through all that pain in order to remain abstinent or have an improved overall quality of life. So, you don't need to put an X on somebody's record in order to teach them a lesson so they don't use drugs. If they're fully functional and they're able to be in school or have a job or be there for their families, then maybe you might want to look at it again and say, it's like, do we really have to say something to them? Because if it's decriminalized, then maybe the perception will change and people won't have to say something. Now that it's illegal, then there still is the stigma. So.
Yeah, I think we need to have decriminalization so it's equal for everyone. I feel as a white person in Cook County, marijuana has been decriminalized for me for a long time. A long time.
We'll certainly be talking about that in panel two.
But if I was a person of color anywhere, that is not the case at all. And I think that decriminalization needs to catch up and be with what society kind of reflects right now.
Anyone else want to answer that question? I'm not trying to make you answer that question because I certainly understand that answering that question is a big question to answer. So,
As a provider, I will say I would love to see decriminalization. I would love to be on the same page as one of my clients when they tell me, you know what, smoking weed isn't that big of a problem for me. I'm functional, I can hold a job, it doesn't cause problems with my relationships. I would love to be on the same page. Right now when a client tells me, yeah, I'm still gonna smoke weed, I cringe. And that's not because I disagree with their choices, it's because I know the legal consequences. And so I would love to see that change.
Yeah, I would agree also, and I mean, I think that the decriminalization solves a lot of different issues. I mean, one being the high incarceration rates, and another being the stigma that's attached to using drugs. I know a lot of people that drink a lot, they binge drink, but they won't touch marijuana. They kind of look down on people that smoke because they say, well, that's against the law. So the only kind of stigma for certain people about these things is that it is illegal, not the dangers or the consequences of the drug in and of itself. And so I think that would go a long way to changing the construction of the issue of substance use disorders. And so yes, I also think so.
well, I know we have questions. If somebody wants, okay. So I don't know if they're directed at people.
There's a couple that didn't mention actual names, but
Okay. Okay, I'm going to ask this question. This is for anyone. Using the term disease increases the seriousness of the issue, but doesn't it also promote stigma? Anyone? Anyone? Anyone?
Or, when I've talked with people who used our services at the methadone program, I wanted to know what they wanted to identify themselves as. A consumer, a patient, a client, what did they want to be known as? I think across the board, everyone at the program chose to be called a patient. They realize that they have a medical problem and they don't want to minimize it. And they want to be recognized as having a medical problem. So they wanted to be known as patients. The job I have currently, I work with people with mental health problems. They prefer to be known as clients. They really don't like the term patient. To them, that stigmatizes them as someone with a mental illness. And we talk about terms a lot. They don't have a term that they all can agree on. Some people actually came up with brain disease as a nice neutral term that they thought described themselves and put them in the same category as people with epilepsy and things like that. People with mental health problems are truly stigmatized in this. They're much more willing to admit to having a substance abuse problem than having a bipolar disorder, because I deal with duly diagnosed people constantly, and almost all of them would much rather be known to have a substance use disorder and not admit to having a mental health problem.
Wow, okay, so we have a lot of interesting questions. In terms of policy and messaging, is ignoring the elephant in the room to make a case for treatment instead of incarceration, this is in quotes, when the vast majority of people who use drugs do not meet criteria for substance use disorder? The source, most recent national survey on drug use and health, and every previous national survey on drug use and health. For
They're
the
totally
past
right,
decade.
totally right. I might even have a reference to that. But yeah, most people that use substances do not have problems with those substances. Think of alcohol. I mean, many, many people use alcohol. Few of those people develop alcoholism. I would
Well,
expect that to be true.
What do you think, is that true of cocaine, of heroin, of methamphetamine?
I would think it's true of opiates. I would think it's true of cocaine. I would think it's true of methamphetamine too, I'll be honest. I think people can use substances and not misuse them. Boy, heresy again. Look at it.
Does anyone else want to respond to that question, or now I got to find another question. Okay. Why, and I'm sorry, this is gonna, I'm just randomly kind of picking these up. Oh, okay, we've got another one, great. Okay. Why is methadone treatment so often divorced from regular health care, and should it be? And I'm going to throw this in to another question is, can ACA help in this? It was for reentry, but I'm going to throw all that, answer that question kind of, why is methadone divorced? Can ACA help that? And, you know, what can we do about it? Anyone?
So with regard to the Affordable Care Act, so really new issue, and most of my clients that come into the system don't come in with health care coverage, and so the ACA could help them a lot, particularly after they get out of prison or jail, if that's what they're sentenced to. I think the issue is there's just not enough treatment providers. So there's gonna, I think, be way more people covered who need and want services than the treatment providers. And I guess the question remains to be seen, will the amounts that are gonna be paid out, will that attract new treatment providers? Because I think there's just not enough beds, as I understand. I defer to our specialists, but that's my understanding of how the ACA might impact. It might help a lot, but we don't have enough beds yet, I think.
Well, why is methadone divorced? Former methadone treatment provider.
Well, I think that methadone carries a lot of baggage as far as treatment goes, more than any other kind of treatment. What was the...
Why is methadone treatment so often divorced from regular health care, and should it be?
No, it shouldn't. You need a special license to dispense methadone in this country. You cannot receive methadone from your private physician for the treatment of drug dependence. You can receive methadone from your private physician for the treatment of pain, but you cannot receive a methadone prescription from your physician for the treatment of dependence. You must go to a methadone treatment provider that is licensed by the government. Why that is, I'm sure there's a lot of conspiracy theorists that have a lot of answers to that. They have come out with a new medication called Suboxone that does not have the same restrictions. But let's see, methadone costs pennies. Suboxone costs an arm and a leg. Methadone, the cost of methadone would probably literally be pennies a day. The cost of Suboxone treatment, just for the Suboxone, $600 a month. We're talking, you know, bond traders and people with excellent insurance that are able to access that care through their physician's office. So I think it would be it would be great if they loosened up the regulations and allowed primary care physicians to get involved treating this problem. Because not everyone has a severe enough problem that's going to require a specialist. Many people, it's a spectrum of problems. If you have a small problem, your primary care physician might be able to help you with that, just like anxiety. If that turns into panic disorder, he may refer you to a psychiatrist at that point. But right now, everyone's hands are tied when it comes to methadone provider treatment. And I don't see it changing, really, and I haven't heard of anything that's going to change that. Yeah.
Methadone is not the same drug as Suboxone. They are
No, it's not.
No.
Right. So all I want to do is they're not the same drug as Suboxone. Suboxone is also regulated. There are only so many providers that can just give Suboxone in the same way methadone. It just doesn't have its own clinic. It has the provider status.
But any primary care physician may take the course of 30 hours and be allowed to prescribe Suboxone. You don't have to be a psychiatrist. You don't have to be, you can be a primary care physician and take 30 hours of training and provide Suboxone. Now, you have to be willing to do that. Primary care physicians are not necessarily going to open up their practices to what they consider undeserving patients.
Well, I agree with that. I think there's a stigma.
There's still a stigma for that.
Is the question, what I hear is, there's limits on Suboxone, the number of patients.
Yeah, there's limits on all of this, unfortunately.
On medication-assisted treatment unless it's abstinence-based. Okay. What are Lucian's thoughts on drug consumption rooms, facilities that allow drug use and supply clean needles and medical supervision for people who inject drugs?
Thank you for asking that. I think that would save a lot of lives. And I think that as long as you have the proper staff and supervision there, you know, to prevent overdose, you know, I think it will take the fun out of actually having to go to the ghetto to cop drugs, let's say heroin, and risk being caught or being sold something that is cut or laced with something else, you know, which can risk your life. I think if you have an option to go to a clinic and administer clean heroin with supervision, eventually I think a lot of people may get bored and might want to quit. That's just my thought. So.
Yes, you may.
To be clear, they don't provide the heroin.
You have to bring.
You still have to cost.
Oh, well, about that, I mean, I guess that's what they have. That's why they have the naloxone kits. Yeah. So I mean, as long as people are trained to administer that, you know, I think. Well, I know that that Kathie is doing that. She's training, you know, and like you know, one of her policies is that if you're going to use again, use with somebody and have a kit, you know. And I'm all for keeping people alive and safe. In the last 3 months, I've had 3 friends die because of overdose. So,
dead addicts don't recover.
Absolutely. Someone asked a question about why are there no African American people on the panel, and I just do want to address that question, which is, hey, folks, you know, next year please reach out and contact me because I would love to include more people of color on the panel. But I think that the question is, if Black minority communities are affected the most, where are the Blacks on the panel? And I think when we're talking about the criminal justice response, we cannot deny that. And I think that I want to apologize for that. So, I mean, I could not have read this question, but and it doesn't make me right for reading the question, but I think it's an important thing that we need to keep in mind, and so I just want to say I apologize for not having people of color represented in this experiences. Part of this, it's, you know, in any case, my deepest apologies. And for folks who are interested for next year, because, hey, it's the 5th annual Forum on Drug Policy next year, and it's the 10th anniversary of the founding of the consortium. When I founded it in 2005, I did not think we would be here 10 years later. I didn't even know. Hey, I mean, I didn't know what I was doing at all. I had no idea. So, you know, and I still really don't know, as evidenced by my panel, who has no people of color on it. I'm sorry.
I would encourage you to get involved with this.
I'm sorry, Marcia.
Hey,
Marcia.
I represent the Latinas, okay? Also, I think it's great that there are white people on this panel. Hello, they're aware of the issues. I think that's wonderful. Now, if we can get some more people of color up here, I'm all for it.
Absolutely, and we will work towards doing that. But on the same post-it note, what happened to prevention programs provided to children in Chicago elementary schools and high schools? The Chicago Police and the DARE program. I'm going to answer the DARE program. DARE program was found ineffective in like a ton of studies. So the state of Illinois defunded it. Are the Chicago Police effective in providing education around substance use? When we do research with young people, we find that, you know what, they actually really don't want to learn about drugs from police. I don't know why that is, but they don't want the deliverer of their drug education to be a police officer. Perhaps that makes them uncomfortable, although some people do like the dog. But so, you know, I think that is a major issue. We've had huge, tremendous cuts in funding to prevention, but I think our prevention framework is also equally weak, and I'm going to make that point. I don't want to keep us too long. It is 3:30. I know there are probably some really awesome questions that I didn't get to, because you know what, there's just a whole bunch of, and it's hard to, but I want to keep us on time. So if you want coffee and some cookies, now is the time to get them. And if you want to go corner a panelist, now is the time to do that. And I just want everyone to thank the panel for a lively discussion. I think it was very